145 millimole, considerably less common than hypernatremia, associated with mortality rates as higher as 40-60%, caused by a relative deficit of water in relation to sodium, which can result from net water loss, accounts for a majority of causes, pure water loss, hypotonic fluid loss, hypertonic gain, results from iatrogenic sodium loading. Causes: net water loss, pure water loss, unreplaced insensible losses, dermal and respiratory, hypodipsia, neurogenic diabetes insipidus, post-traumatic, tumor cyst histiocytosis, tuberculosis, sarcoidosis, idiopathic, aneurysms, meningitis, encephalitis, Guillain-Barré syndrome, congenital nephrogenic diabetes insipidus, acquired nephrogenic diabetes insipidus, renal disease, medullary cystic disease, hypercalcemia or hypokalemia, drugs, lithium methoxyfluorine, amphotericin B, vasopressin B2 receptor. Hypotonic fluid loss, renal causes, loop diuretics, osmotic diuresis, glucose, urea, mannitol, post-obstructive diuresis, polyuric phase of acute tubular necrosis, gastrointestinal causes, vomiting, nasogastric drainage, enterocutaneous fistula, diarrhea, use of osmotic catheters agents, lactulose, cutaneous causes, burns, excessive sweating, hypertonic sodium gain, hypertonic sodium bicarbonate infusion, ingestion of sodium chloride, ingestion of seawater, hypertonic sodium chloride infusion, primary hyperaldosteronism, Cushing's syndrome. Clinical manifestations, hypernatremia is identical. Most manifestations are neurologic in nature: fatigue, headache, nausea, vomiting, confusion, seizures, coma. Presence and severity of symptoms are related to severity of derangement, speed at which the derangement develops. Diagnosis, history and physical examination. History should focus on the presence, absence of thirst, polyuria, and or an extrarenal source of water loss, such as diarrhea. The physical examination should include a detailed neurologic exam and an assessment of the ECFV. Patients may be hypovolemic with reduced GVA and orthostasis. Accurate documentation of daily fluid intake and daily urine output. Lab investigations, measurements of serum and urine osmolality, in addition to urine electrolytes. The appropriate response to hypernatremia and the serum osmolality more than 295 MOSMOL per kilogram is an increase in circulating ADH and the exertion of low volumes, less than 500 milliliters, of maximally concentrated urine. A urine with osmolality more than 800. Management, a two-pronged approach addressing the underlying cause, correcting the prevailing hypertonicity, rate of correction, hypernatremia that developed over a period of hours, accidental loading. Rapid correction improves prognosis without cerebral edema, reducing Na plus by 1 millimole per liter per hour appropriate. A hypernatremia of prolonged or unknown duration, a slow pace of correction prudent. Maximum rate 0.5 millimole per liter per hour to prevent cerebral edema. A targeted fall in Na plus of 10 millimole per liter per 24 hours. Goal of treatment, reduce serum sodium concentration to 145. Make allowance for ongoing obligatory or incidental losses of hypotonic fluids that will aggravate the hyponatremia. The patient with seizures prompt anticonvulsant therapy and adequate ventilation. Administration of fluids. Water ideally should be administered by mouth or by nasogastric tube as the most direct way to provide free water water without electrolytes. Alternatively, patients can receive free water and dextrose containing IV solutions such as 5% dextrose. Hypernatremia with ECF volume contraction.
What is ECF يعني؟
extracellular fluid.
بيعرف؟
extracellular fluid.
Yes.
Hypernatremia with ECF volume contraction isotonic saline is given initially till ECF volume is restored. Subsequently, water deficit can be replaced with water by mouth or IV 5% dextrose or 0.45 NaCl. Hypernatremia with increased ECF volume, since the hypernatremia is secondary to solute administration, it can be rapidly corrected. Patients are volume overloaded. Loop diuretic is given along with water to remove excess sodium.
Thank you so much. يلا خذ لنا حضور. معناها 10 minutes break. الحضور والغياب بالمحاضرة رقم 6 مشان نضمن انه